Morning, everyone. Thank you for joining us at the medical webinar. Today, we're going to talk about will COVID-19 boost the acceptance of telehealth in Malaysia? We have our moderator again, Dr. Arul, Director Policy and International Relations from Malaysia Medical Council. Do you want to start off?
Yes. Good morning to all our panelists and all our participants. Welcome to this webinar titled COVID-19. Will COVID-19 boost the acceptance of telehealth in Malaysia? Firstly, I'd like to thank Ms. Amira from My Seminars for inviting me to be the moderator for this webinar. As we are in the midst of this global pandemic, our healthcare delivery system is facing a very unprecedented time. This pandemic has brought the use of technology to the forefront. Healthcare workers are now able to utilize technology to improve access to care for many of their patients. Though technology has eased the access to care, it is pertinent to note that virtual consultations are still subjected to the code of medical ethics, whereby the rights of patients have to be protected. With this, I would like to introduce our two panelists this morning. First is Dr. Thirunavukarasu Rajoo. Everyone knows him as Dr. Arasu, who is the Honorary General Secretary of the Malaysian Medical Association. Welcome, Dr. Arasu. And next is Mr. Hazwan Najib. He's the co-founder of DoctorOnCall. So both of you all, welcome to the webinars. So first, I'd like to call Dr. Arasu to proceed with his presentation.
Thank you, Dr. Arul, for the kind introduction, and thank you, Carmila, thank you, Hazwan, and good morning, everyone, the participants. I think the topic is a very interesting topic. That is, will COVID boost the acceptance of telehealth in Malaysia? And I believe that most of you all will have some idea on that part. Okay, what I am going to talk about today is that before we talk about telehealth, I think it is very important for us to understand the basic of healthcare. That is us as patients. Okay, telemedicine is just an enabler. It's just a technology. It's just an enabler. It's a mode of communication. But we just go back to understand what actually patients are actually looking at. Okay, the next slide. Okay, we need to know the health and treatment seeking behavior of patients. Okay, how do they seek treatment? What is their nature? What is their behavior when they fall sick or they do not fall sick? What are the options they have for them to get this particular treatment or consultation? And in Malaysia, because if you see that we do not have a national health system, it means a one payer system, and then we have a dichotomous system, public and private. Okay, we notice in the, be it public or private, we do see clinic or physician hopping because there is no centralized system over there. And then the treatment seeking behavior of patients are also quite different. And it's also interesting to know what is their journey in seeking the treatment. If you look at it, most of them, when they fall sick, sometimes we take home remedy. For example, if you have flu, what do? Sometimes we take with honey with lime, warm water, air swam, okay? Or you take maybe Vicks vapor up. I'm not promoting Vicks. I'm just telling these are the things you may use if you're having a simple flu. Or even if a tummy pain. I know when I grew up, it was, I can't remember what is what in English. There's a concoction they used to give, but it worked very well. You see, I'm talking about 30, 40 years ago. And then, of course, the other option is that clinic kesihatan. You can either go to clinic kesihatan, you can go to GP clinic, and those who are the top 20% will choose to go to private hospitals and see the specialist straight away. Or we can also go to the public hospital, mostly in the outpatient department. But as we all know that there's also abuse in the emergency department where people go for simple cases like fungal infections, just simple headache, you know. And of course, people also self-treat by going to the pharmacy. As you know that some medications you can buy from the pharmacy, especially OTC drugs. And of course, patients nowadays also, they seek treatment, they seek advice or even up to treatment via online health services that's being provided. Okay, when one of these options fail, for example, home remedies, if it fails, then they go and seek a healthcare professional, either through clinic kesihatan, GP clinic, in a pharmacy, or in a online health services. So the other third option is that they may see in a clinic kesihatan, GP clinic, pharmacy, and online health services, and finally not well, they hop again to a GP clinic. So this is in the summary of the health and treatment seeking behavior of a patient. Next, please. Okay. If you look at healthcare, you see today we are talking about, okay, we are only talking about what you call it, clinical side, when a person falls sick. So now the question is that the only factor that determines the healthcare? If you notice, they have done research, and then in fact 20% of a person's overall health and well-being is actually based on the social determinants. Okay, if you talk about social determinants, these are, it could be because of hunger, no food, it can be access to care, it can be language and literacy, housing in a crowded area. I think we have reports where I think in something flat or whereby children are malnourished. You know, housing area, what are the things that happen in a very housing area? Transportation, whether can they travel? If you look at places like in Sabah, Sarawak, they have issues with transportation, and also education level, and then income and jobs, and also environment and safety. So these are also other factors that social determinants, which are 80% of the component of the healthcare. Okay, if you see globally, we are also seeing the trend of, because of technology, a lot of research and development has been done because of the data. Today we see the increase in life expectancy, and then we also have seen improved health outcomes globally. So these actually have come to a point when you grow older, you do not have the system needs to be robust. The system also needs to support, because when you grow older, you also become very vulnerable to fall sick, and it become more expensive to manage the person if they do not take care of themselves at a younger age. So what happened on a yearly basis? The cost of healthcare is just skyrocketing. It's just going up. And on top of that, you need to manage the chronic diseases, which is escalating, fueled by societal factors, and also the individual behaviors themselves, whereby the person supposed to be responsible for their own health. But today we do see them, how do they outsource to the others? Okay. And then the impact of social determinants on health and healthcare costs is actually beginning to outweigh the impact of health factors alone. So when you look at healthcare, you do not look into the hospitalization and when a person is falling sick. It is also important to understand why a person falling sick, and what are the 80%, what is the 80% of the social determinants which are actually causing the person to fall sick. Okay, next slide. Next slide, please. The slides can be shared. I think somebody asked just now, the slides can be shared. Okay, let's look at the patient demographic and also the mega trends. Okay, if you look at the patient demographic, this is based on some of the studies that MMA has done a few years ago to understand the type of patients that visits GP clinics. So what we have noticed, 80% of the patients who are visiting GP clinics, they are in the age group of 19 to 60 years old. That explains why, because they're wage earners, they're earning. So they are supported either by employment health benefit or out of pocket. Okay. So if you look at that, at any point of time, whether in the year 1990, in the year 2000, 2010, 2020, the age group is always 19 to 60 years old is the bulk of the patients. But a patient who was seen in the 1980 and a patient who being seen in the 2020, they are different because they are born in the different age group. If you look at now, they could be born in 1960, 1970, 1980, 1990 or 2000. Their expectation of healthcare is different from somebody who's born before the 1960s. So this is where most doctors are caught actually. A doctor will be in the clinic for maybe 10, 20 years. He'll be thinking in the same group of patients, but actually their background are different. Okay. Then if you notice, 60% of patients who are coming all are female patients. Okay, and 70% of patients were actually married. That means a household are seeing in the GP clinics. And then 85% of them have a certain level of education, degree, diploma, and secondary. And then if you realize the broadband subscription in Malaysia is more than the population itself, and the penetration rate is 121%. Forget about the internet stability, but this is the level that I got it from the MCMC website a few years ago. Then if you look at the mega trend, this is already happening around the world. It is something that we cannot stop. Okay, the market will change, the market will adjust. Here the markets are patients. Okay, from fee for service, we are moving towards patient-centric. That means the focus is on the patient, the treatment is wholesome. We do not treat just one individual like that. And the decision making is a shared decision making process. It's no more, I tell you, you listen. Saya doktor, saya tahu, you just ikut. That was those days. Today, we give the options to the patients. We tell them this is this, you're having this, these are the options. You decide which one is best for you. So it has to be a shared decision making. And then it has to be value-based care. It's no more fee for services. What are the values you're giving to the patient? It's not only giving medication. What are the advices that you're going to give to the patient? How are you going to monitor them? If it's a chronic illness, how do you monitor them? It's a journey. And then you're talking about population health. If you see clinics, especially GP clinics, they are catering for a certain community. So how do you maintain the certain community's health? And how do you do that? It is through digital health, and digital health is very important. Then when patient comes to your clinic, that means you take the information, you take the necessary data, basic information, weight, height, your BP, your temperature. So all these things are basic information which are very, very important to develop a population health as well. Okay. And then when you have this data, you can move towards digital therapeutics. Digital therapeutics is basically how can you monitor a patient with all the data available that can guide them. And then of course you are talking about integrated health network. It's all connecting. Today we see in Malaysia, we are all disintegrated. Private do not talk to each other. Do not talk to each other means the systems do not talk to each other. There is no continuity of care. Today, a patient comes to a GP clinic, you would have done a test, sent to another hospital, they would have done a series of batteries of tests, investigations. Then if they go to a hospital, for example, public hospital, the whole tests are repeated again. So if you have an integrated health network, you can save so much of time, so much of cost. You can save. So this is what the trends are happening all over the world. We believe Malaysia also working towards that. Okay. Surprisingly, okay, these are what are the important healthcare factors influencing decision-making process in a patient? When a person falls sick, what are their priorities when they make a decision? See, based on a study done by PricewaterhouseCoopers in the US, okay, the number one is all about convenient and easy access. For them, very simple. If I want to go here, okay, can I park the car here, do my banking work, do my sundry shop work, and then send my children for a kindergarten or tuition, and then see a doctor? Okay, how convenient, easy access? Is it easily accessible for them? If I want to talk to a doctor, can I just call him up? Can I just go into telemedicine and talk to them? This is what they're looking at. And number two is that who is actually paying for it? Okay, do they have insurance coverage? Is somebody paying for it? You see, this is what they're looking at. Only number three, they're looking at doctor and nurses' conduct. That's number three. And then number four, they're looking at brand reputation. If they're choosing to go to a healthcare sector or a facility, they see, oh, they do a review, whether they check Google or whatever they check, they see whether is this a reputable facility for them to check. And number five is quality of care. Number five is quality of care. That is what the market actually is looking at, surprising to all of us, right? Next slide, please. Okay, basically, this is just a brief summary about, I'm not going to say much about this. Basically, this is just about what is telehealth. is basically anything done via phone, it's messaging, video, text message, or web-based services. Okay, so basically what we need to understand, there are three elements in telemedicine, telehealth. Okay, number one is that patients, they provide the data about their health. Okay, and this data is transferred to the healthcare professional electronically, and then the healthcare professional uses their skill, professional uses their skill, their clinical skills and judgment to provide personalized feedback to the patient. Yeah, this is where the item number 3 is where there are lots of medico-legal implications. The healthcare professional, they must know where to draw the line. To what level of advice can they give? So they need to comply, because at the end of the day, if they were to just keeping advice and then giving treatment, if anything were to go wrong, in healthcare it's very simple. Everything will run smoothly. When something goes wrong, the entire thing will get disrupted. Okay? And then, of course, if you look at the telehealth, actually telemedicine has a lot of things to offer, especially remote care to patients, health tourism. Today, you see during COVID, patients cannot travel. Malaysia's market size of health tourism is, I think, more than $1 billion. You see, and then patients are communicating with the doctors from Indonesia or Vietnam or Bangladesh. They're communicating with doctors over here. And then mental health. We have noticed that during the COVID-19, where there's an increase in cases of people are getting very stressful because of all the negative news every day about COVID, and also the mental pressure due to loss of job, loss of income, financial burdens. Okay, and also patients are also looking at basic health consultation. Can they talk to somebody if they're not well? Okay, so basically there's definitely a need, and telemedicine is here to stay. Next, please. Next slide, please. Okay, this is a typical online health services. Okay, this is a relationship. The relationship is the same, that healthcare professional and then you have patients. Okay, earlier it is a physical meeting, and today there's a technology called a platform that enables us to communicate. Okay, if you look at the healthcare professional on the left-hand side, they are highly regulated. There are more than 52, 53 laws regulating them, and high exposure to medico-legal cases. And then if you look at the patient, we need to ensure patient safety. We need to ensure standard of treatment is maintained. And we need to maintain the client and patient's right at all times. So all these 53 laws are actually to protect the patients. So if anything were to go wrong, the enforcers will go after the doctors. And then if you look at the platform that providing the commercial platform that providing this technology, they're not regulated at this point of time. We know the government is working towards developing this legal framework for online health services, which we fully support. And I think many of the players are also fully supporting that. Okay. And currently what we notice is more towards transactional consultations. It's just the commercial transaction. Today, what do? We download various from Google Store or App Store, right? We download so many applications because of RM1 or $1 we just download. How many of it actually we are using it? So healthcare is also moving towards that. Okay, I got somebody I just called here and there. You see, so we notice that it's very transactional consultation. There is no relationship, a long-term relationship, continuity of care is not there. Okay, and then we see is commodified and more commodified is more my term, and also commercialized healthcare. Today we are complaining. When we see in the hospitals, we say why the bill is so expensive. But many of them are not aware the professional fees are regulated. In any bills of the hospitals, only 30% is the professional fees. 70% is the healthcare facilities bill, which are not regulated. So why? It's because of heavy commercialization, listing, you keep all these things, okay? Okay, and then the question of continuity of care. Okay, now my last slide. Next. Okay, basically, as I mentioned earlier, we have to adopt online health services. There's something that is inevitable, is going to happen. Okay, it has to be patient-centric and shared decision making, or whatever I said is there. Is something that we all have to adopt because that's what patients are looking at. Okay, we can incorporate telehealth. Some of the challenges that incorporating telehealth with payment gateway with the clinical management system, the quality of data that is captured, And also we encourage doctors also to digitalize their practice, and also how do we connect to secondary and tertiary care. And my last one, please. Okay, basically change is the law of life, and those who look only to the past or present are certain to miss the future. So we hope, while we do not want to miss the future, but we must also ensure patient safety and quality of care is maintained all the time, and all the medical legal issues are also addressed during this delivery of service. Thank you, Dr. Arul. Thank you, everyone.
Thank you, Dr. Arasu. Thank you. Next, we'll proceed to Hazwan with his presentation.
Thank you, Dr. Arul. Thank you, Dr. Arasu, for such an elaborate presentation. I don't think I have a lot more to offer, but perhaps maybe I'll just make a few comments first based on Dr. Arasu's presentation. And after that, if I can, I'll just share a couple of slides from mine as well. Right. I mean, first of all, I think all your observations are absolutely correct. There is an element, we have been around for a few years now, there is an element of increased patient adoption over time. And of course, COVID-19 kind of like boost that adoption by about 3-4 times. Right. But I think since it's great to see that MMA, Dr. Arasu herself, like, like pushing the industry from the practitioner's point of view in terms of adopting digital health, right? And I think this is a time where, because the adoption is a lot more, so practitioners need to, I believe this is the time for doctors and practitioners to play a role in educating the patients if telehealth consult is appropriate for whatever conditions that they have, right? Before this, a lot of patients are making their own decision, right? But now we need to see more point of views, like more comments from the healthcare professionals. Secondly, in terms of what telehealth has to offer, the one that Dr. Arasu mentioned, I think telehealth or teleconsult is just, right now, it's just a scratch at the bottom of what the whole digital health has to offer, right? We haven't, the teleconsult is just a communication platform, right? But we have yet to move into the whole remote monitoring or devices. There's a lot more to actually close the gap of telehealth where there's no, where doctors can't do physical examination. But a lot of things, as you said, there are a lot of laws governing the medical industry. I'm talking to Dr. Arul now. I mean, devices, right? Say for instance, a cardiologist want to monitor patient using one of those, say, Cardia Mobile for the mobile EKG, right? If the patient were to present us, okay, look, doctor, this is my chart, right? If the doctor choose to believe that chart, like what is the implication, what laws is protecting and not protecting the doctors and things like that. And I think there's a lot more role to be played by, say, a medical device authority in terms of making sure all these things are in place and empower and eventually empower and enable the doctors or the practitioners, right? And and the last point that I'd like to make about that Dr. Arasu mentioned about consultation tends to be transactional on telehealth, so there's no relationship that is built. I completely agree with you, but since earlier this year, I've been thinking a lot about this as well in terms of the patient behavior now. Everyone is mobile, everyone just move around, except for CMCO, of course, but no one really like stick to one clinic, one doctor anymore. But the only way to actually bring back this whole sort of like family doctor or relationship-based doctor concept, I believe digital has a big role to play here, the connectivity, right? So imagine you have a physical relationship with one clinic in town, you're traveling to Penang, you can still use telehealth to reconnect with the doctors if you have some problems in Penang and whatnot, right? So that whole connectivity actually plays a big role in pushing this digital health adoption forward, right? And eventually, because everyone connects on digital now, WhatsApp and whatnot, right? And once every doctors or clinic have that platform, then you can actually bring back those relationship-based physician-patient relationship back into the mainstream. Okay, Dr. Arul, I don't know, Camila, how do I, can I just share my screen from here if you stop sharing your screen?
Ambero can help, can assist.
No, it's controlled centrally.
Oh, okay. Right. I'll just do this. Okay, can you see my screen now?
Yep, go ahead.
Okay, I only have a couple of slides. Maybe I wouldn't take more than 5 minutes to go through this. What I'm showing you now is actually the whole internet, the growth of internet healthcare market, the projection before COVID. I haven't seen any, good credible data on post-COVID yet, right? So this is from a couple industry analysis. The before COVID, even the internet healthcare market it's growing at about 27% year. Is expected to grow at about 27% year on year. And in terms of adoption of online doctor visit, it was about 7% globally estimated in 2018, but it shows it's continued to grow at about a quarter of the, about 25-26% of the visits by 2025. And I believe with the whole pandemic, this number is no longer relevant. It is gonna go a lot more, grow a lot more. And the next slide related to how I would name this, is a patient-driven industry. In Dr. Arasu's word just now, it's about patient treatment-seeking behavior. Right, so even if you look at we always use this doctor to patient ratio, like 1 doctor to 632 doctors in many of the stats that we use, right? So if you think about all the digital trend, right, whether people adopt ride hailing or whether people adopt internet or any digital services, is always driven by the consumers or patients. So when telehealth come into play, right, there's a lot of behavior that is driven by the patients. I'm talking about even the social media marketing, the health myth, the trendy health marketing, right? Many practitioners are actually working hard to dispel some of the bad behavior, I would say, or bad trend that's coming from patients, right? And the problem is before telehealth, before all this telehealth become mainstream, the internet health or the digital behavior of patients are very detrimental to the patient. So have you heard of Google and then self-medication? And then and one of the pet peeve of ours is, even if you Google diabetes, it's fine. You get, if you're English speaking, you Google diabetes, you get to WebMD, Healthline, one of those US websites. But try Google kencing manis, right? You get to product peddlers, the traditional drugs treatment and all of that, right? And of course, patients, that's what they do, right? They Google, and we cannot stop them from doing all of this. So that's why I think with the introduction of telehealth, we actually empower the patient or the practitioners to actually disseminate better information and influence a larger group of people, right? To actually, look, you don't have to resort to self-medication or self-treatment when you can actually like speak to a proper qualified doctor, right? Yeah, so I think Dr. Arasu sent some of this trend in his slides about the digital adoption, how people go to the net to look for health information. When we first started, our idea is just this, right? It's nothing clinical about this flow, but right now, before these patients were not given options, right? If they have issues, you either, so they Google and self-medicate, or they go to the doctors in person. But most of the time, there's no like so-called like halfway point where patient, okay, almost like triage, right? For patients before they go in. And on the health consultation as well, there's a lot of preventive window or preventive or health seeking window that a lot of patients don't choose to go into a physical clinic. For instance, like a young lady who's a lady who's trying to get into the birth control or family planning for the first time and asking doctors what can or cannot be done, or someone who's having irregular period but doesn't command so much irregular period, but just probably delayed for months or years before they start going to see a doctor, right? So those are the kind of behavior that we see. A lot of patients, especially in Malaysia, are more comfortable, like, you know, asking the doctors online first. They say, if the doctor say it's something a lot more serious, then you can go and see the doctors in person. So this is the idea, right? But this is an old slide. We don't want this. I think we don't see this anymore during pandemic. And this is my last slide, right? This is what we see based on some of the initial use cases that we see in telehealth, right? There's various stages of healthcare, right? So a lot of things before primary care, or I mean halfway through primary care, the early symptoms, concerns, delayed care, prevention, minor non-urgent care, mythbusters, go or no go screening, right? So a lot of that can be addressed through telehealth, right? And of course, once you get to the tertiary care, the follow-up, the therapies, the post-consult care definitely can be done on telehealth. So this is the view that we have with regards to telehealth, right? And I have to say that the patient adoption, I mean, just my concluding point, what we see in the last 6 months, of course, the patient adoption has doubled in Malaysia. Luckily, we sort of control COVID-19, so we don't see the 300-400% increase like what happened in Colombia or the US or China, right? But there is that increase in adoption. But what is more exciting is there is a lot of increase in adoption by the practitioners or by the doctors who wants to actually set up their virtual practice online. That's what we start seeing. Right. With that, maybe I'll pass it back to Dr. Arul on Q&A.
Okay, sure. Thank you, Hazwan. For the participants, if you have any questions, you can type it out in the chat box. I think the panelists will also have access to the chat box and they can reply, give you an answer for your questions. So let me start with all the questions. Dr. Arasu, as you know, we have mandated the requirement for medical indemnity to practice in Malaysia. So do these online consultations, are these covered by the Malaysian, these indemnity providers?
Okay, as far as the indemnity providers that MMA has endorsed, when we checked with them, they said as long as it is covered by the law, and then I think they said they covered, it's okay. So I think the good part is that the MMC has come out with the advisory on the virtual consultation. So currently that is what is being used as a document.
Okay.
If you are going to provide online health services.
How about if you are having a teleconsultation with a foreign healthcare provider?
Okay, I think based on my various stakeholders' engagement with the ministry and also MMC, I think this is something that what I came to know, correct me if I'm wrong, Dr. Arul, you're in a better position. I think it has to be done in Malaysia. If something is overseas, because the person has to complain. The complainant, where is the complainant from? And where does this took place? So I think these are the gray areas where I think we also be asking this from the government as well. So they make it very clear how do you address all these kind of problems. So I don't think so I'm able to answer the question directly, Dr.
Okay, all right. Just wanted to explore. Huh? Okay, how as we know, the very famous case of Lee Hsien Loong, the Singapore Prime Minister, whereby his medical records were hacked and all the information was available online. with regards to that, I would like to ask, how does DoctorOnCall actually ensure the privacy and security of patient records and data?
Okay, thanks, Otaro. I think two things. One is we use only the proven cloud provider that doesn't have any record of security breach when it comes to healthcare data. Right. Secondly, all the key standards I can't really list them down that is required. Even though HIPAA compliant is not yet enforced like in Malaysia, but we follow that global standard to make sure that the patient privacy and data is protected. And there is also the third one is actually the way the data transferred between doctors and patient. We learned this not trick, but this sort of flow from when we're studying some of the platforms in China and India, in terms of say you have a database, right? And at what point can the doctor access the patient data, right? So we only allow that window where the doctor can access if the patient requests for the particular doctor's consult, and you can access the patient history. So the doctors cannot go like, oh, I just want to say, hey, I want to find Dr. Arul's record lah. Just go through almost like going through the filing cabinet. So we don't allow that. But what we know that some of the platform initial one, no one really think about that. But that is actually one of the major breach if you think about it, right? So we have very specific algorithm to make sure that the accessibility of the data is on a very specific window, right? And of course, if there is a request for data, we need to go through a proper process.
You said you are using cloud as your storage.
Yeah.
Just would like to ask whether does Mampu actually allow patient data to be stored in the cloud?
I believe there is no law against the cloud solution. It's recommended to be on the local cloud, right? So if it's like players like provider like Alibaba Cloud has a local presence here. Yeah.
So the local cloud you are allowed now.
Yeah. Recommended because.
Recommended. All right.
Because I think what we, even last year when we discussed in Digital Health Malaysia, everyone's debating about the data sovereignty and all that, but there is no law pointing that it must be in Malaysia. But of course, KKM always recommended the data to be in Malaysia.
So if you are using this telehealth, definitely after the consultation, there will be such thing as you need to prescribe medication. So definitely you will need the pharmacists also to be involved in this whole network of healthcare delivery. So do you think the rural sectors in Malaysia will benefit from this advancing technology, or will they be left out of this development? Dr. Arasu?
Thank you, Dr. Arul. That's a very good question. As I pointed out in my slide, I will still maintain that at the moment, it is very, very commercialized transactional consultation on telemedicine. But in terms of rural area, we have to complement the Ministry of Health, where they are already doing telehealth for rural areas, especially like in Sabah, Sarawak. It's all being done. So this is where actually you see the biggest benefit actually in terms of the health outcomes. Because why? If you look at the health issues in the country, we need to see what are the health burden to the country. NCDs, mental health. So whatever solution that we have, the solution is already there. So that is where when we start seeing more of this happening towards the rural area, I think definitely they'll benefit the most.
Thank you, Dr. There was, in the last budget, there was RM 1.5 billion ringgit allocated for electronic medical records, if I'm not mistaken. Any update on that, Dr. Arasu? I think you were quite involved in that in the talks.
I think what we need is a political will. It's very simple as that. Electronic medical record is something that we should have done 10 years ago. Is a missed opportunity actually. Lots of data are missed. So I think no matter what, this is something it must be prioritized. But before even they talk about electronic medical records, which sounds nice, they need to ensure they have good internet connectivity. All their computers are all upgraded. Okay, these are the basic things. When we speak to people on the ground, they said, how are we supposed to do all these things when our internet connectivity also is not very good, and then our computers are also using processes of 10 years ago. So I think government need to spend more money. As I told earlier, this is something they should have done 10 years ago.
Yeah, exactly. Coming back to what you just said, the whole this technology, I mean, it's outdated. It becomes outdated very fast. It evolves in a split second. Okay, but if you look at the healthcare facility, they have all the resources to upgrade their equipment, and then they can put in requirements. You know, if you want to use our teleconsultation, you must have Windows 10, you must have so and so processor speed, you must have this much of RAM. But if you look on the ground, can the patient actually upgrade and upgrade and upgrade, spend money upgrading the system just to have this teleconsultation? Is it actually feasible, Dr. Rasu?
No, actually, it's very feasible because nowadays with the handphone, you can do everything. You can do banking transaction. You see, we need to benchmark financial institutions. If you can do banking transactions very secure, I do not see why we cannot do in healthcare. So the issue is that the political will is the government, the industry is serious. Is the government serious on this? It's just like to be fair with those who are providing online health services. The government is not providing with the legal framework. Everybody is asking for that. MMA is asking for that. I think Hazwan is asking for that. Everybody is asking for that. Once the legal framework is clear, it's very easy for everybody. Good for patients, good for providers, and good for healthcare professionals. So again, I would say it is the government that is actually dragging their feet on this.
I see.
Taro, if I may just add on.
Sure, please do it.
EMR, right? I mean, we have, if you look at the industry, there are like over 160 plus EMR players and yeah, all over the world as well. When we first started going to the industry, we ourselves are a bit perplexed in terms of why is it so difficult for me to access my even blood report from one clinic across to another, and why is it all disintegrated and all that, right? I think the issue is when this kind of budget come out, right? If I don't know 1.5 or 3, I don't know about the budget, but it's just that everyone is trying to build thinking that okay, EMR is gonna be a massive platform. I heard this word cradle to grave and that whole concept, right? Which is require a huge amount of planning, thinking, and building. I would say maybe a Rolls Royce, right? But I think a lot of things that needs to be solved are actually has to be simplified, right? I mean, start simple of building a connectivity or of accessibility of the current information, right? Rather than trying to put in requirement that is so prohibitive and so complex, right? And gonna cost a lot of money, right? And then like the project kind of like cut halfway through, right? So simplification, I think, should be the theme for any of this like large scale effort for EMR or connecting all the medical records. Yeah.
That if you just see, Dr. Arasu said we've got more than 53 laws governing the medical practice. So we actually be adding more laws to it, more laws and regulations to govern the medical practice.
Yeah.
So how do we actually look at this? How will the medicine actually reach the patient? How can the doctor ensure that correct medication reaches the correct patient? Dr. Arasu, both of you can answer this. I think Hazwan is in.
I think Hazwan is in a better position
he's
because he's already doing that.
This,
yeah.
How do you ensure that the correct medication reaches the correct patient?
Okay, 2 ways. We have, for us, it is a challenge. It is a worry as well when we first started. But what we realized is we have almost like 18/7 operations team that is connecting patients, that is actually coordinating between the pharmacy, the patients, and even delivery partner, right? So any issues, you must come back to this full-blown operations team that is helping patients through this. and they won't say they won't even release the delivery partner to go and pick up the medication if they can't reach the patient or the patient is not at home. I said, okay, the patient is at home, you must be there to receive it, right? Some delivery partners, we even use that code, the code, like, code 1234. Okay, you give the right code, then the pharmacist give you the medication. At home, the patient, what's the code 1234, and then you pass the medication, right? But there is other technologies that some delivery have the variation of that for every delivery partners as well. And secondly, of course, in terms of we make it a policy that not to deliver any substance or drugs that is highly abused, right? For instance, like for any class A dangerous drugs and all those, we make sure that we don't deliver any of those. We have a lot of requests, but yes.
Oh.
Yes.
Okay, for the participants, if you have any questions, please do type it in the chat room. It's you're very lucky to see Hazwan and Dr. Arasu here. So please take the opportunity to ask them all the questions that is flashing before your mind. What are the other challenges actually you're facing, Hazwan? Or any limitations to your practice?
I think, of course, regulation is one thing. I mean, everyone knows that, everyone is working in the gray almost until MMC come up with that guidelines, but it's still an advisory, right? So it's not law per se. The laws that Dr. Arasu mentioned, a lot of them are a bit archaic, but we know that it's gonna take 2-3 years to actually change the law. So what we're saying that there must be when KKM is doing that regulatory study, right? We're always pushing for regulatory sandbox where we can practice safely in an unregulated because in the absence of the regulation. I mean, for instance, right? I think with regard to Private Healthcare Facilities Act, where required to be in a physical clinic and I mean to do the consult for telehealth, right? Can you allow the patient to the doctor to be in home office, right, to do the consult, right? So it's still like questionable at this point, right? So that's one thing. Secondly is my second challenge is, of course, educating or guiding the healthcare professionals or the doctors in terms of using this telehealth platform correctly and properly as well. So because I think many doctors, we make sure they for whoever who come on board, they do a proper training and proper guidance. We work with some of the say FMS as well in terms of the primary care to make sure that we have a proper guidelines for the doctors to handle patients on telehealth, right? Yeah.
Because so you've got the internal training mechanism for your doctors.
And it's an evolving thing. We keep trying to make sure that the training is done properly in the absence of the proper training guidelines for telehealth. Yeah.
Okay, understood. So when patients come in, do you accept new patients or only follow-up patients, whereby that you already know the history, which is more advisable, Dr. Arasu?
Yeah.
Using telehealth, can you accept new patients but you do not know the patient?
Okay, as far as a practitioner we are concerned, if we accept a new patient, my advice to my fellow practitioners that you must know your limitation, because you do not have the medical record, past records of the patients physically. So as long as you're providing advisory, so normally what we will do, I'll provide an advisory. Anything more than that, I say you please come, because we are of the opinion that the first consultation, it has to be face-to-face, because why? The medico-legal exposure is very high. So we will always encourage the follow-up patient, but having said that, we do not stop, but we must know our limitation.
So where actually to draw the line?
This is where your clinical skill comes in, your experience comes in. So let's say a person is coming with, let's say for example, I'm having abdominal pain. I will never take a risk.
Okay.
Because we know even during physical attendance of abdominal pain, we can overlook certain diagnoses. So we wouldn't. If somebody is coming and talking about more towards a mental stress, just having a small mild flu or something very mild. So that is where, even based on the MMC's advisory, we must know, at the end of the day, it is the onus of the doctor. the responsibility stops at the doctor. So that is why what we are concerned that more and more young doctors are going into this telemedicine without understanding the medico-legal implications.
Yeah, the legal
It
implications.
just needs one case where maybe even their license might be revoked, or if something happens to the patient, allergic reaction or whatever so, and how do they protect themselves? So we got to be very cautious on this.
Hazwan, have you come across patients with mental health issues seeking treatment via your?
I would say every 500 patient, we have one. Okay, so there's two, right? There's no formal request for mental health consult, right? What we have is actually patients who tend to, when we start talking to doctors, and doctor realize that the patient just have a mental health issues, and then try to guide the patients to try to refer the patients to a psychiatrist or proper counselors, proper channel. So we have doctors who had to speak to a patient for close to 1 hour on the phone, right? So the patient that just doesn't want, but that's the doctors made decision to just continue talking to the patients. Sorry, maybe 1 in 1,000 patients. One thing is we haven't really onboarded any counselors or psychiatrists onto our platform yet. I think we are working on it. But in terms of demand as well, we have this scattered, and many of them they can't even afford as well to actually have a proper counseling or mental health services on the platform. Yeah.
Any questions for the panelists? Also, anything to add?
Nothing much to add actually.
Compared to our immediate neighbor on the southern border, where do you think we are in terms of telemedicine? Tarasu.
I don't have the information what is the level of usage in Singapore, but I know in terms of they are more structured, they are more systematic. They've come out with a guideline on that, how to do telemedicine. They started the sandbox much earlier than us. So they were more well prepared than us. How much? I'm not very sure, but definitely they're ahead of us.
Hazwan, I'm sure this platform that you are using has been used in many other countries. Can you share some of the experience or any of that you know of?
Yes, when we built the platform, we're looking a lot at US and India in terms of the platform. So in the US, there's players like Teladoc who's very focused on working with the insurance and the corporate or the employers to roll out their telehealth, and we took after their model mostly when we built this. But the last December when we went to China, Shanghai, we were visiting Ping An Good Doctor, right? At that time, they're doing 700,000 consults a day, right? This is before COVID, right? So you see their big screen, and then one doctor, I can say the doctor is, the way they structured is they have a doctor and a team, like one doctor have done like, about 1 million consults to date. I can't even imagine like how did that doctor. So that's one observation, that the volume is huge. When you have that kind of volume, right now we are, as I said, we are scratching the bottom of the telehealth in terms of teleconsult, connecting patients to doctors. But once you have that kind of volume, AI has to come into play, right? So what I was informed was there's a lot of pre-assessment AI sort of like assessment, and before they even prescribe and all that, the doctors will then have a final word with the patient and then go through the checklist and then like dispense the medication. So that's one. Secondly, they have that 1-minute clinic where after speaking to doctors in a booth, and then the back there they just drop they have a vending machine to give you the basic medication. So that's Ping An Good Doctor. So once we caught up with them after the pandemic recently, During the pandemic, they're doing about 10 million consults a day.
Wow.
Yeah. So that's China, and that's most impressive for us. That's a gold standard in terms of the technology for telehealth or teleconsult. Yeah.
So I presume you'll be implementing it here soon, huh?
In terms of what the AI, is it?
Yes.
No, I can't even. We can't even properly get a guidelines. We just recently got a guideline for telehealth, which is patient speak to a doctor, right? I think AI will take some time, right?
I've read there's a report where the accuracy of AI diagnosis is about 85%. Any comment on that? Do you know anything about that? Diagnosis by AI compared to a practitioner.
Yeah, so there is a players like Babylon who was working with our partners Prudential as well. They do have those claims in terms of the AI diagnosis. For me, it has to be tested, and I have not seen it done or live data done in at least a Malaysian context. So I would not make any comment, right? So any of those, so a lot of them are actually translating those AI and diagnosis. But I think most importantly is the healthcare practitioners and the regulators like MMC have to be able to be comfortable with that those kind of diagnosis or those tools. If I just add one more point about the Ping An, they maintain that AI tools is not for patients to self-diagnose or for AI to diagnose. It is to support the doctors in doing their job, right? So imagine if you actually get the patient to say yes and no to a series of questions, that will help you, because I mean, practitioners are also human, right? Sometimes you may have forgotten to ask certain questions. So those tools should be the enabler for the doctors and healthcare professionals.
So Dr. Also, with this advent of this artificial intelligence, AI, do you think the medical profession has found a challenge?
For me, it is a compliment. I look at it as a compliment because why? I think we cannot run away from technology. And then technology is actually based on data. They capture data and mathematics, probability. It can only assist us. Like for example, X-ray. There's already X-ray reporting on using an AI. Yeah. Because certain things that the eyes may miss out, the numbers won't miss out.
Yes.
So I think the doctors, they don't have to fear that. I think we should embrace, and then we should use it to the advantage of our patients. But the challenge is that ultimately, the decision, the medical-legal implication is not to the AI, it's to the doctor.
Yes.
So it is how we do it, yeah.
Hazwan, so now the new generation of doctors are coming into the market. So many definitely they would want to explore various platforms, So what is your advice to these new young doctors? They want to they venture into this like something like a DoctorOnCall. What is your advice to them?
Okay, so if for your information, we hire for our patient care team, right, or operations team, right, we hire a lot of medical graduates before they enter housemanship. I think in the last 3 years, about at least 180 of them have gone through DoctorOnCall. So we have a little community of young doctors who then, and my hope for them is always like, look, you are going into the field, you're going to the practice, right? You should look out, because I myself, I'm not a doctor, right? You should look out for all the good use cases, how this technology can help the patients and bring back the ideas so that we can co-develop and do all these things together. So I think that's important for the new generations of doctors to keep pushing the boundaries and advancing this whole digital or telehealth. Right. So that's what I've always hoped from this young doctors, but there are a younger generation doctors who are probably the MOs who are coming out of the KKM system. Many of them, what I discovered, that there are also a lot of doctors that are coming into the industry. They are, it's just that some of them are not lucky to have their own private practice, right? So they have very good, very good knowledge a very good relationship with the patients, especially those doctors in, say, clinic kesihatan, because they are the one that's closest to the communities and working with the communities in the primary care setting, right? So and many of them are young as well, so they are the one that is actually like coming to us, also like asking, oh, can we join the telehealth platform, and can we do this? So that's when we have to make decision as well, like, okay, if we onboard the set of doctors, like how do we make sure that they know what they're doing in terms of practicing on telehealth, right? So that's why we had to, you know, work with a couple of say even senior doctors at FMS to make sure that whatever we do on telehealth, right, or by these young doctors, younger generations of doctors, are proper, right? So we have always practiced caution. Yeah, but the best thing is they're very open and very quick, right? So the patients are also very comfortable with the doctors who can just like quickly get on the call and help them.
With this technology in place, many doctors also feel there's no need to have a physical clinic whereby they incur all this overhead costs, whereby they need to rent, they need to hire staff, and using this platform will be a much cheaper way of running the practice. What do you think of that, Arasu?
See, healthcare is not as easy as what we are thinking. See, healthcare, even though a patient in an urban area, they may have 4 doctors. One is the doctor at the place where they stay. One is the place where they work. One is the place where the babysitter. One more, the place, a friend who is a doctor. And number 5 is Google Doctor. So they have this. So we know one patient has this. But having said that, for simple acute illness is different. But when somebody is having a long-term medication, long-term medical problem, so this is where the continuity of care, the relationship that builds between the patient and doctor. See, most of the patients, no matter how modern they are, they do listen to doctor to a certain level. So for these kind of things to happen, you need certain examinations you cannot be doing online. There are certain things you can do online, we agree, but there are certain things we can't do online. The patient has to come to the clinic, we need to speak to them. So I think, in my personal opinion, this is just a compliment. Online health services just a compliment for the patients in their journey of seeking treatment.
We have got this age-old doctor-patient relationship, Dr. Arasu, whereby their rapport is built over time. Do you think this technology coming in will detach this doctor-patient relationship?
Okay, I've been in the practice for the last, in the private practice for the last 12 years. I've adopted EMR when I first started private practice. In fact, all our clinics are connected. Our EMRs are connected more than 5 years. Okay. And I do not see there's the patient-doctor relationship dropping. Even my younger patients, I do give my numbers to them, mobile numbers to them. They don't disturb actually. I just give them some time for emergency. They want guidance. That's all. But I do not give medical consultation. I say, you're having this problem, maybe who should you go? This kind of advices I give them. But I do not see that relationships going down. See, at the end of the day, they value your services. See, at the end of the day, it's not the medicines you're giving. It is the service that you are providing to the patient at that point, at the time of need. And that relationship, no matter what technology comes in, it won't go. But if you're providing transactional consultation, that relationship will not last.
Okay. There's a question from our participant. Telehealth seems to be a good system that really help and ease patient. I'm just wondering, since establishment in Malaysia, any medical legal issues that have come up? Any medical legal involving telehealth?
Okay, we have had a few cases whereby doctors prescribe medication, Group B licensed medications without prescription. we are still waiting for the enforcers to revert.
What about e-prescription? Is it valid?
Currently, there is what do you call it? There is an amendment on the e-prescription. E-prescription. It was supposed to be tabled in the last parliament sitting.
It's going in now this time.
So I think this time it's going in. So I think once that is done, at least the e-prescription issue will be resolved.
Yeah. Okay, Muhammad Sofian is asking, what's the criteria for a doctor to join DoctorOnCall? Wow.
Must have APC, valid APC. And that's a minimum criteria. But
working experience, how many years working experience do you need that?
We get our medical director to interview the doctors as well as go through the training. So there's a bit of hoop as well. So it's not just, okay, sign up and then you can start talking to the patient, right? Because we want to make sure that the experience given to the patient is proper, right? So the doctor have to go through a bit of a training, maybe like about 2-3 hours of training over a few sessions, and then mock calls and all that. Then we let the doctors that serve the patients, and plus we are also dealing with a lot of the corporate patients and insurance patients who have very high expectation on the service. So even the basic training of giving proper introduction and proper closing in a call, it needs to be reminded over and over again, because it's not something that you do naturally in a physical setting, most likely. Like say, hi, I'm Dr. Arul from this and this, how can I help you? Like even the basic I have to be reminded over and over again, because if the patient feel like the doctors is a bit like garang or a bit curt, right? The effect on a platform via digital platform is very bad, right? Yeah. So there is that element. Secondly, any medico-legal issues? Yeah. So far we don't have any medico-legal issues that has arise, right? And I think this is most important from the doctor standpoint as well. Their limitations and know their risks, right? So they have to, if they're not comfortable, you still get paid for the consult, and then you can always refer the patient to go to the physical setting, physical clinic, go get tested and whatnot, right? So the doctors is not like forced to prescribe and give medication if they're not comfortable, right? Yeah.
Okay, we've got the next question here. Based on principle of medical negligence, when and to what extent doctor's duty of care involved in this telehealth, since it involves with AI and practitioner not physically examining the patient? Anyone of you can answer?
Dr. Arul, you have to answer that one.
Azul.
MMC. Yeah, actually this question is Puncak Kuasa is to MMC. I mean, I can say, no, basically like what the advisory guideline says, we still need to follow the Medical Act. What is stipulated in the Medical Act and also what is stipulated in the Code of Professional Conduct, that still applies. So technology is technology, but then the conduct of the physician is still the same.
Yes, actually this is done in good faith. The Code of Professional Conduct still stands, and if there is a complaint, the council shall investigate. Hazwan, just now you said you actually do hire medical graduates. What do they do actually, medical graduates?
They are the people that we call patient care team. They're basically operations team. So they handle the doctor. Sorry, they handle the operations. Basically, if there is a hotline request for patients to speak to a doctor, so they actually create the case and patch up to doctors and patients. They handle the fulfillment of medication. If there is medication prescribed, they handle the customer service, they handle the payment. But most importantly is they actually our seamless communicator between patients and doctors, right? Because they have a bit of medical background. I mean, they have medical education, so they can actually explain to the doctors what the patient's having. Because sometimes the patient call back to the hotline, to the operations line, and it's actually during the call just now, there is this issue that I forgot to ask doctors and say, for instance, right? And then they are the one that, okay, can I patch the doctors back to you? And before they do that, they actually explain to doctors, the patient said this. So is we found that very seamless between communicating between the doctors and the patients.
Okay. In case of emergencies, how do you handle emergencies? Because if you got a case while your doctor is online, and then you realize that oh, this is an emergency, how would you handle this as well?
First of all, we have to put a disclaimer that this is not emergency, so please don't. Second very major decision that we made last time. We thought, okay, let's open this 24-hour virtual clinic, right? But what we realized is anything after midnight, all the way to 8 a.m. in the morning, right? Those tend to be more acute emergency cases that we would be a disservice if we were to be operating. Right, so we actually stop we only open between 8 to 12 midnight, right, for the consultation. So anything after that, you have to go to emergency. If the doctor discover an emergency case, our SOP is the doctors have to quickly direct them. Either call 999, or actually we never had a situation where the patient is completely cannot help himself, or that's a protocol. But I don't think we have had any emergency cases, but maybe a lot of red flags, right? So doctor, I think you quickly go to the physical clinic or emergency room, right? But it's not
With the current pandemic, COVID coming in, so are you getting a lot of consultations with regards to COVID?
That's for me.
Yeah.
We offer free consult with regards to COVID. Last time when working with KKM, KKM also staff some of the FMS, their doctors to help with the COVID virtual health advisory. That time was crucial. I think we're talking about period between February to April, because a lot of people are so scared, right? People are like, oh, I think I shared a lift with someone from China, or I have a lot of bats at home. So a lot of misinformation, a lot of people are just going all over the place. Imagine those people who are scared, like flooding the healthcare facilities like Klinik Kesihatan for testing, right? So during that time, that channel, COVID-19 helped. We have in fact about 5 million people that came to the portal. About 2 million did their self-risk assessment for COVID, and we did probably about 50,000-60,000 consults on COVID alone. Yeah.
Dr. Arasu, I'm sure you are aware of this AI technology being used to predict outbreak of dengue. Have you come across that?
Yeah, I think it was done.
It was done, yeah.
Yeah, dengue or something like that.
Yeah. Do they have it for this COVID to predict?
I think the MySejahtera app should be.
Only the MySejahtera app now.
Should have, because that's the only solely collecting all the data, and hope that whatever the SIM card is collecting, MySejahtera is collecting all these things. Hope that MOE is having a big data team at the back.
Hope it's integrated, the whole system.
Yes.
Hazwan, someone is asking you how much is the payment. I think that one you can put your email address there. They can contact you directly.
Sure.
You can just type in there your email address, and they can facilitate all the personal questions. Any other questions from the? Okay, is telehealthcare considered as a private healthcare service? 586. It's monitored by CCARE, CCARE. If not, which agency or bodies? Dr. Arasu.
Okay, very good question.
Under 586. Yes.
We have been pushing, because the problem is that Akta 586, it mentioned private healthcare facilities.
Facilities. Yes.
So MMA has been pushing the ministry to remove the word facilities, just like what Singapore has done. Private healthcare services. So that means it encompasses everything.
Everything. So as of now, not yet for the question . So it's still not regulated. Any other questions from the members? A lot of participants. Yeah.
Sorry, maybe I actually have a question. Maybe Dr. Arasu can comment on this. In terms of consultation rate, physical, I know there's a lot of discussion on the GP's consultation rate in the last few years, right? But now we're talking about physical versus a teleconsult. What is your view on how the GP should set their consultation rate?
You see, the current consultation rate is, as you know, that is 1992's rate given by MMA. Okay, so basically, if you really want to look at the benchmarking of consultation rate, we should look at the 13th schedule, that is 30 to 125, which was actually gazetted in 2013. Okay, so basically, I would look at that benchmarking. That means minimum, we are talking about at least 30 ringgit benchmarking. So at the end of the day, patients should not see this as a transactional consultation. This is a professional providing healthcare services. So I would say it should be at least a minimum of 30 ringgit. But it all should be quantified with time. Now, since with telemedicine, since they log in, you know the timing. So actually, MMA has done something on simple, intermediate, and complex. Simple means if you spend up to 10 minutes is 30 to 50 ringgit. And then if intermediate means is 51 to 80 ringgit. That is up to 20 minutes. If anything more than 20 minutes, we're talking about 81 to 120 ringgit. This is what MMA has proposed last time. So the same thing can also apply. Maybe slightly lesser, but the same thing can still apply.
Yeah.
Hazwan, I'm sure all the doctors working for you have to have their own indemnity. Any idea what's the coverage like for indemnity? What's the requirement of minimum coverage?
We also found out only after 2 years running the service that I thought all the doctors have the medical indemnity insurance, but I just realized that it's just been
mandated by law
recently, right? So when I asked, so a lot of time when the doctor asks, what if the medical indemnity cover this? We say, okay, what provider do you have? Actually, I don't have. so that was we found it by accident as well. But for medical indemnity specifically, we encourage the doctors to get from the providers that specific either they specifically mention that they will cover telehealth. Right, most of them that cover telehealth also cover the WhatsApp, text, chat, email, and all those communication platform. But many of them position it is as long as the telehealth or the digital communication is not in part of the exclusion of medical indemnity, then it should be covered, right? So I think we have a few providers that if the doctors ask us, we tell, okay, there's this one provider that specifically actually cover this. Yeah.
All right. So how do they list the place of practice for DoctorOnCall?
If they are, many of them like working off their own clinic, so they still use whatever that they put in their AMC.
Okay. Any other questions from the panelists before we wrap up? If none, I think I would like to thank our panelists. Dr. Arasu, thank you very much, Dr. Arasu. And,
thank you, Dr. Arul.
Thank you very much, Hazwan. I think it's over to you, Amira. Thank you.
Thank you, Dr. Arul. Thank you, Dr. Arasu and Hazwan. Thank you, everyone, for being part of the webinar. We will email the slides to you guys after this, and we'll see you next time. Bye.
Bye. Take care. Stay safe.
Okay, take care, Arasu. Bye.
Cuci tangan.
Yes.
Face mask.